Good night, and thank you once again for joining in this week's HealthWise. On behalf of the St. Kitts Nevis Medical and Dental Association, I'm your host, Dr. Les Scott, and alongside me tonight on my panel, on my left, I have Dr. Pemberton, and on my immediate right, I have Miss Dr. Dieguez. Okay, tonight we're going to have a very lively discussion on a topic that I think is pertinent at the moment, and that is renal failure and end-stage kidney disease. Dr. Dieguez, I'll let you introduce yourself, and you can tell the St. Kitts public out there in radio land, TV land, and internet land your specialty in nephrology. And I'll let you introduce yourself, and then I'll let Dr. Pemberton introduce himself. Okay?
Okay, good evening, everyone. I am Dr. Dieguez, Dunia Dieguez, a nephrologist. I am working in Geneva Hospital in St. Kitts. Work there in outpatient department at the hemodialysis department.
Thank you, Dr. Dieguez. And Dr. Pemberton?
Good evening to our listening and viewing audience. I am Dr. Duriel Pemberton. I am a general practitioner assigned to the emergency services and currently stationed at the Poxon Hospital.
Okay, thank you. So we'll get right into the discussion. It's about chronic kidney disease or end-stage renal failure. It's an issue that has been growing, I would say, exponentially in our small federation in terms of the amount of persons that's needing dialysis and the necessary care associated with kidney failure and the like. We'll just get right into the discussion. Dr. Dieguez, we're going to start with our presentation.
Okay. Chronic kidney disease is defined as damage of the renal parenchyma that results of chronic deterioration of kidney function and may result in progression to end-stage renal disease. It is a non-communicable disease that includes a range of physiological disorders which are attributed to abnormal renal function, and it is progressive decline filtration rate. There are 5 stages of kidney damage in chronic kidney disease that range from mild kidney dysfunction to complete failure. This problem may happen slowly over a long time. Early detection can help prevent progression of kidney disease to kidney failure.
Awesome. So we have 5 stages.
Yes.
So what are the stages, or how long does it take for symptoms to present itself in terms of in the clinical stages? I know the beginning stages of it may be asymptomatic. So could you break it down for us a little bit?
Yes. In the first stages, the patient not complain any symptoms.
Okay.
Sometimes the patient is in stage 4 or 5. Sometimes the patient need dialysis and is not complaining
Still
yet.
no symptoms,
It's
even
still-
in stage 4 or 5?
It's still not complaining
Oh.
any symptoms, yes.
Okay, interesting.
But the symptoms can include, when the patient starts with symptoms, can include trouble sleeping, poor appetite, weakness.
Slide, please.
More tired, the patient is more tired, have less energy, weight loss, or muscle cramps, is anemic, or needs urinate more, sometime at night.
Okay, so nocturnal urination increases a lot. So is this in the early or the late stages of the progression of the disease?
Sometimes it's the early stages when the patient start with some obstruction problems. Sometimes with the patient have prostate enlarged and can have obstruction and go to the bathroom different times at night, and it's in the first stage. Still, the patient don't have any damage in the kidney.
Oh, so the kidney is not damaged, but they're having symptoms.
Sometimes, okay, because some patients early can have these symptoms, and another patient have chronic kidney disease already, yes, and have the symptoms, yes.
Okay, interesting. So we're moving on to the causes.
Yes, we have different causes of chronic kidney disease. Hypertension, diabetes are more common causes. It's possible secondary to glomerulonephritis too. And less common causes include genetical disorder, such as polycystic kidney disease, Alport syndromes, severe kidney infection, renal artery stenosis. It is when the arteria decrease the lumen and the flow is not good in the kidney, and the patient can develop the chronic kidney disease. Autoimmune disease like lupus and Goodpasture syndromes, heavy metal poisoning, kidney and urinary tract abnormality before burn, and obstruction caused by kidney stone, tumor, or prostate enlargement.
Oh, so if you have kidney stones and it's not treated, can it lead? I guess eventually can lead to kidney damage. But I wasn't aware that it can also lead to end-stage kidney failure if it's not treated. You mean?
Yes, if the patient have kidney stone and have obstruction, can develop to chronic kidney disease, or if have several infections secondary to the kidney stone too. Yes.
So I would like us to even touch more on the hypertension and the diabetes, because I know that those are two non-communicable diseases right now that I would like to think a good amount of our population, we suffer with that. So is it just that because they have hypertension it leads to, or is it that the uncontrolled aspect of the hypertension or the diabetes?
Yes, it's more frequent for uncontrolled.
Okay, so in other words, if the patient is controlling the blood pressure and taking their medications, and possibly if they also have diabetes and also controlling the diabetes, they have less risk for developing renal failure.
Yes.
Okay.
For example, in the patient with diabetes, the patient coming to nephropathy diabetes, and that nephropathy diabetes have five phases. Mm-hmm. In the first phases, when the patient have blood sugar high and don't have control, mm-hmm. the patient can the glomerular, this is the filtration of the kidney, increase the size, and in the first stage, and the patient still don't have any symptoms. Mm-hmm. In the second stage, the patient start to lose some protein, mm-hmm. less than 30 milligrams in the urine, and it's still reversible in that time if the patient continue with control.
So the proteinuria would be the marker, would tell you that the person has compromised kidney function.
Exactly.
So then the amount of protein will tell you the degree. So yes. Is that where you determine the stage? Is it?
Yes, the stage in this case, in nephropathy diabetes, when the patient is in the third phase, the patient start with microalbuminuria. It is between 30 to 300 milligrams in 24 hours, the protein, mm-hmm. and these patients in this stage is still reversible too. Okay. The patient.
Oh, so even if they have kidney damage, it can be reversed?
No.
Not so when it's
no.
So we can reverse it.
It is the case. Uh-huh. With diabetes patient, mm-hmm. with uncontrolled blood sugar, and it is not still in chronic kidney disease, because in stage 4 the patient starts to chronic kidney disease, and this stage is irreversible.
Okay, so from stage 4 onwards it's unreversible, and that
stage 4, the nephropathy diabetes.
Okay, so that you will call this one chronic if it's at stage 4.
It's stage 4. It's the patient starts with chronic kidney disease. The protein is more than 300 milligrams in 24 hours, and the patient in this stage needs continued with control of blood sugar, need to continue with treatment with ACE inhibitor to control for example, control the proteinuria, and this treatment in this stage is for avoid the progression to the stage 5.
To stage 5.
Yes, to stage 5.
So could you repeat, how do they correct the proteinuria?
Okay. Stage 2 on nephropathy diabetes is less than 30 milligrams in 24 hours. Stage 3 is between 30 milligrams to 300 milligrams. It is microalbuminuria. And the nephrotic diabetes classic is when the patient has more than 300 milligrams in 24 hours. This stage, the patient has chronic kidney disease, and is unreversible. Okay? When the patient has more than 300, it's unreversible because it starts with proteinuria.
Okay, and so polycystic, we're going to move on. Polycystic kidney disease, that's a genetic disorder where the person is born with a congenital issue with the kidney itself. Is it that the kidney doesn't function, or it's less than what it's supposed to be functioning?
Congenital, the patient still have good function of the kidney, have the risk. And when the family have polycystic kidney, need to follow by nephrologists, because sometimes when have 20 years or 30 years start with the failure the kidney.
Awesome. And with the severe kidney infection, can you give us an example of what could cause a kidney to become infected?
Okay, severe kidney infection is more frequently when the patient have obstruction. Sometimes we have kidney stone, and the kidney stone is inside in the kidney and can remove it. The patient had infection, and in the first stage, in the first time, don't complain anything, and the infection continue, and that's obstruction. The urine can remove because it's still in the kidney, and it's severe because it's pyelonephritis. The infection is in the kidney. It's not in the urine system. It's inside in the kidney.
Okay, yes. Gotcha. Okay, so can we continue? So how is diabetes linked to chronic kidney disease? This would be a very important risk factor for us to learn about here.
Yes, diabetes is a serious lifelong condition where glucose level in the blood are too high. If untreated, it can lead to serious health complications, including damage to the kidney. One of the complications of diabetes is kidney disease, also call it diabetic nephropathy. This can affect it up to thirds of people who have diabetes. It develops over many years and can affect anyone with diabetes. This is caused by damage to the small blood vessels in the kidney. The blood sugar high increase the inflammations substance, and this one affected the filtration of the kidney, and this is the nephropathy diabetes that I explained to you.
Okay, awesome. So I'm seeing here that the kidney affected by diabetes can look normal under an ultrasound. So if the kidney is looking normal, because I know it's supposed to show some symptoms of swelling, and that would let you know if it's inflamed or not, if it's out of the parameters of what a normal kidney should be. So as the nephrologist, then how then would you know that it's an infected kidney? I guess you would have to monitor the fever and temperature of the person, but how then would you know that it's the kidney that's causing the fever?
Infection is not chronic kidney disease.
Okay.
If the patient has fever, back pain, urinary tract infection, it's possible lower urinary tract infection and not affect the kidney. But if that infection is repeat and repeat, or if the patient continues to have some antibiotic, nephrotoxin, the antibiotic, that can produce chronic kidney disease.
Okay, interesting. So would you suggest that persons who suffer with diabetes or hypertension, whether it's controlled or not, I guess it would be safe to be screened for kidney disease at least once a year? What do you suggest?
The patient with diabetes need to follow up by blood tests, looking for the waste substance high, for example, creatinine, because creatinine over 1.3 is when the patient start with elevate the waste substance in the blood. No? The urine analysis, looking for urine protein, and the ultrasound is good for check the size of the kidney, looking for causes of mass or tumor or kidney stone. In the first stage with diabetes, the ultrasound can be normal. When the patient is with chronic kidney disease in the end stage, decrease the size. And we looking for, because we can get some information by ultrasound. But for the diagnosis is glomerular filtration rate. That is, the doctor can calculate that with the age, with the gender, and with the level of the creatinine.
The glomerular
filtration rate.
The filtration rate.
The filtration. This is the diagnosis for know what stage what stage is the patient.
In your clinical practice, I'm going to come over to Dr. Pemberton. In your clinical practice with your diabetic patients, as a local, how do you find it in terms of educating your patients? Are they compliant with their medications, non-compliant? Because I think that would have a huge bearing on the progression of the diabetes also, and if they're at risk also for kidney disease. What do you have to add to the topic, like in terms of persons with diabetes or hypertension? How do you find our population? Can you give us some insight? Are the persons around here controlling their conditions, or?
No problem. So we always advocate for persons with the non-communicable diseases to keep them controlled once they're on medication, and to have their routine follow-up with their primary care physician. Why that is important? You go to the doctor today, he may run some tests, etc. Everything may come back fine. So that person may go living and behaving as if all is well. I could act a bit careless. Sometimes they do not take the control drugs, and then the situation gets out of hand. Bear in mind, these conditions such as chronic kidney disease, it's slow and progressive. So you may be having some damage now, but it's not showing up. Over a few years' time, when it is that significant, yes. So it is important to take your control drugs, especially the hypertensive, the diabetics, and have the regular scheduled visits with their primary care physician and follow-up visits. Sometimes it's done biannually or annually, and that is to make sure the condition is not getting worse, and they would screen for renal failure amongst other stuff, so that it can be detected early and reverse it as much as possible.
So that's something that's done with your private doctor. Is there any
yes.
public service screening?
So public service screening is done at the health centers.
Okay.
And it's really a clinic management. Remember, I'm an emergency physician.
Gotcha.
Yes. So it's at the health center or with your primary care physician.
So then, as an emergency care physician, when we have in holidays and Christmas and this and that, would you find persons now, they take the opportunity to not comply with taking medications? Like, do we have a season around the year for certain conditions that are increased or less?
With the chronic kidney disease, like I said, you may not see a significant jump because it's something slow and progressive yet. But there are times where, like right now, mango season coming in. Everybody got a sweet tooth, and even the diabetics, they want a taste of the mango.
Mangoes.
And so you find the sugar would tend to get out of control. Again, around any festive season, they would overdo it at times. So they have to pay particular attention to that as well.
So how do you get your male patients to get over the myth of, about the lack of functioning of other areas of their life if they take their medications for hypertension and diabetes? I've heard some patients voice some concerns about lack of sexual function. So how do you encourage them? Because that's a real scare for a lot of men. I find when I was doing triage at the emergency room, some of them would come, entire crisis, and when I asked them why they were not taking their medication, and they would empathically tell me it's because they've heard that it can affect their erection and all of these things. So if a man is facing an existential crisis where he thinks he's going to lack sexual function when he takes these medication, how do we mitigate that?
There are alternative medication within the treatment and control, even though there are some that may cause an effect on the sex drive. Okay, there are alternative medications to control whatever condition they're going through. At the same time, prevention is always key. So if you can eat healthier and avoid certain risk factors so that you do not reach into that category to have to be somewhat dependent on the drugs to control the situation, which may just happen to affect your sex drive. Let's avoid all of that.
Would you like to tell them which drugs those are, or are we going to keep those for another time? So,
stick to the topic.
Yes. So we're going to move on. So how does hypertension affect the kidneys? We're going to take it back to Dr. Dieguez.
Okay. Hypertensive is a complex and is a sequela with multiple factors, and including reducing nephron mass, increased sodium retention and extracellular volume expansion, symptomatic
the nervous system.
The nervous system, yes. Overactivity, activation of hormone, including the renin-angiotensin aldosterone system, and the endothelial damage. The endothelial damage is the most important in these physiopathologies. I
don't understand what do you mean by reduced nephron mass. So the kidney itself now would start to lose its.
Yes, one kidney have million of nephron. Nephron is the system of filtration, filtration system. And when you lose one nephron, you lose in the function. And when the endothelial vessels have some problem, the kidney have necrosis, and you decrease the size of those nephrons. Yes.
Okay, so then when this happens now, we're going to have an increase of sodium retention, meaning they're going to have edema? Kidney edema?
Yes, when the patient has retention, yes.
Okay, so we can continue.
Persistent high blood pressure can damage the tiny network of blood vessels within the nephrons, called glomeruli. Glomeruli is inside in the nephrons. Yes, that filter blood and transfer waste to urine. High blood pressure can compress and narrow the blood vessels, with eventually damage and weakness throughout the body, including in the kidneys, the narrowing, reduced blood flow. If your kidney blood vessels are damaged, they may no longer work properly.
So it's a bit of stenosis in the area, basically.
Yes.
It's a bit of more restricted. So is it that the vessel itself, does it become, like brittle?
Yes, have some damage in the endothelium and died.
So it's
that's
fragile.
nephron died. Yes, that necrosis in that. Yes.
Oh wow! So then that's where the necrosis will come from.
Yes.
Okay, I understand.
And that's why too the patient lost the kidney function with the age, slowly, but lost in the kidney function with the age, because that nephrona died and have necrosis slowly, but
wow.
process.
Okay, interesting. So we have the chronic kidney disease stages. So we can go through one by one. You want to explain, if you can?
Yes.
Stage one?
Kidney disease have 5 stages, and that stage are according to glomerular filtration rate. If the patient has more than 90, this is the first time. The treatment in this stage is only control to all risk factors. The same to the second stage. It is when the glomerular filtration rate is between 60 to 89 milliliter per minute. This is middle, reducing the kidney function. In this stage, the patient needs to observation and continue with the control of all risk factors, blood pressure or blood sugar or another risk factors. In stage 3, that's 2, 3A or 3B. 3A is when the glomerular filtration rate is between 45 to 59 milliliter per minute, and 3B between 30 to 44 milliliter per minute. In this stage is moderate, reducing the kidney function. In this stage, the patients can start with symptoms, start with anemia or different modification in the phosphorus or calcium metabolism, and need, of course, continue with control to all risk factors. In stage 4 is when the filtration rate is between 15 to 29 milliliter per minute, is severe, reducing the kidney function, and in this stage we need to start to preparing to dialysis treatment to stage 5. Stage 5 is when the filtration is less than 15, and it is the end stage renal disease.
Okay. So that's when the patient will now be on dialysis?
Yes.
Okay. Okay. Interesting. Do you know, like, off the top of your head, like, how many persons, like, percentage-wise, of your patients, how many of them are end stage, do you think? Like 25%, 30% of our patients here on the island might be end stage?
In the island? I have some patients here with end stage, and they are not still in hemodialysis.
Okay.
Because it still have with some medical treatment, or are very elderly patient and have dialysis.
So just because it's end stage does not necessarily automatically mean that they're going to be on dialysis?
Yes, the patient need dialysis, but we have some protocols here because our department is very small, and we have some protocols. Okay?
I understand. I understand. That's interesting. I just assumed that because if they're end stage, I just made that association. So what are the risk factors?
Okay, risk factor include, and anyone can get chronic kidney disease at any age. However, some people are more likely than others to develop kidney disease. You may have an increased risk for kidney disease if you have uncontrolled of high blood pressure, diabetes type 1 with the onset of disease before age 20, poor blood glucose controlling people with types 1 or types 2 diabetes, cigarette smoking, which further constriction renal blood vessels, the obesity patient, which contribute to hypertension, the risk of diabetes, and street drugs such as ecstasy of Molly can be risk factors too.
So I would like to even touch on, because right now I won't even try to, how should I say, negate or go around the issue of the street drugs. I'll make a disclaimer, I'm not a person to try and tell anyone how to live and which lifestyle choices they should take, but I would admonish you to know your family history. If you have a history of a family history of diabetes, a family history of hypertension, then I would expect that, or I would admonish you to be very mindful of the lifestyle choices that you make in terms of your drinking intake, your smoking intake. If, for instance, some persons, when they go out to party, they might want to have some fun. I would just admonish you to know your family history. If you have a history of hypertension, then you can't indulge in too much Guinness. I've heard of the nurses who deal with some of the kidney patients. This was a concern of some of the medical practitioners, that persons who engage in certain lifestyles, for instance, they might want to, how should I say, if you're going to have fun, just pick and choose what you're going to have fun with. I'll just leave it as that. Okay?
If you have a genetical predisposition and have other risk factors too,
yes,
you have more possibility to come.
Yes, especially with the Molly, it seems to be very popular right now. I will let the young people know that it's very easy to get a stroke with Molly, because it really it causes your blood pressure to spike. So if you already have a family history of hypertension that you might not be familiar about, and you develop the habit of using certain illicit drugs, you might just find yourself on a fast track to kidney failure or kidney disease that you didn't anticipate. Anything to add, Dr. Pemberton, with your clinical experience? No? Okay. So we'll continue. So the risk factors would include, we're at the non-modifiable risk factors.
Yes. We have non-modifiable risk factors. For example, the age, we can change the age.
But here in St. Kitts, what's the average age of persons you find having kidney disease? Because I feel like overseas, when I studied, I found that it was like middle-aged persons going up. It's happening earlier. So
the persons even in the 20s.
So that's what I'm trying to get at. Why is that we're having such earlier and earlier, even with diabetes and hypertension, we have earlier and earlier onset in the Federation? Is it a diet or a lifestyle issue?
This diet is lifestyle, and it has to be properly investigated. One of the things persons have to look at too is the genetic component. For example, if one or both parents already have chronic kidney disease, that person already getting a jump start in their life with it.
Okay.
And so it just may manifest earlier in their lifetime.
Because from what I understand, diabetes and hypertension are also genetic as well.
Yeah.
So if you have diabetes and you have hypertension, that's a genetic bloodline in your family, then we have to be really extra careful, even from early ages, do our diet. And I'm not sure if we are understanding that as a federation.
And then I know one of the problems we do have here, maybe it's reduced now. Years gone by, parents, they were a bit conservative with their medical information, and so their children, they would have known about it years long after, maybe when they actually get sick down, pass away, they may hear it from an aunt or uncle, oh, your mother, your father used to suffer with such. When, had they known earlier, they could have been looking out for certain signs and symptoms, getting screened earlier for these diseases, so that it would somewhat weigh off the early onset.
Okay, that's interesting.
And the blood pressure, sometimes hypertensive patient can start early. Some children have blood pressure high, and it's asymptomatic, and nobody look for that, nobody check it, the blood pressure, and it's possible be hypertensive very early and
Understood.
damage, yes.
Okay, so we're gonna take a break and we'll come back with some more very interesting information that I'm sure you guys are dying to find out the rest. Thank you very much. So you want your tea?
It's a sore throat. I'll write a prescription and see the nurse regarding the MMR vaccine.
I heard on social media that the COVID-19 vaccine came in a container with the MMR label on it.
Measles, mumps, and rubella vaccine is in the vial, no other.
True?
We can't betray our parents' trust. St. Kitts and Nevis has always had an impressive immunization history.
But these diseases aren't around now.
Yes, our borders are open to all kinds of diseases that negatively affect our children and elders.
I never thought about that.
Today, you have a choice whether you get vaccinated. So, you want to continue?
Yes, doctor.
I want to be protected.
Check your doctor or the Ministry of Health to get the information on immunization against childhood diseases, including HPV and polio, and COVID-19 vaccine for elderly persons and persons living with non-communicable diseases.
We will never give up the fight. Feel the temperature rise, souls intensify. It's time that we realize that we must work together to thrive. The world as we know it, the sky and below it. Could I never have more wonder? Yeah, with life and all you see and the climate's changing, but hope is remaining. And we can't ignore the future. It depends on you and me. Caribbean Sea, it's a part of me. We're all in this together, even if we are apart. Moon and all the swan, tú le mundo son. We're all in this together, no son para beyond. One chance, all that we got. One voice, together we start. Take care, the world where we live. Permite a todos vivir. Tomamos la oportunidad. Nous en dépendons tous, notre planète Terre. Je n'ai pas imaginé un jour un monde sans vie. We're never losing, as long as we're moving
towards a better future. It belongs to you and me.
Let's be persistent,
we'll be resilient.
we're all in this together, even if we are apart. Y todos sabemos que todo lo que hacemos, we're all in this together, afecta nuestro mundo. One chance, all that we got. One voice, together we start. Take care, the world where we live. Permite a todos vivir. Tomamos la oportunidad para guardar la humanidad. And I must leave no one behind because we are one. it, the sky and below it. Could I never have more wonder? Yeah, with life and all, you see now everything's changing.
But hope is remaining.
And we can't ignore the future. It depends on you and me. Yeah. One chance, all that we got. One voice, together we start. Take care, the world where we live. Permite a todos vivir. Tomamos la oportunidad para guardar la humanidad. And I must leave no one behind because we are. One chance, all that we got. One voice, together we start. Take care, the world where we live. Permite a todos vivir. Tomamos la oportunidad para guardar la humanidad. And I must leave no one behind because we are. One climate, one Caribbean. We're never giving up the fight. One climate, one Caribbean.
Welcome back from our small break. Before we left, we had a very stimulating discussion about risk factors of end-stage kidney disease, and we're going to continue where we left off.
Okay, so I'm going to continue with the presentation with the non-modifiable risk factors, and the non-modifiable risk factors, as the heading would indicate, are those that we cannot change. Okay, so when we look at age, chronic kidney disease is more common in persons aged 65 years and older. Persons aged 45 to 64, there's a 13% chance, and those 18 to 44, 7% chance. So as we see here, it doesn't necessarily mean that it affects older persons. It can also affect the young and the middle-aged ones. With the ethnicity, low birth rate, it is associated with impaired kidney development, resulting in fewer and smaller nephrons. Now, if your kidney is not of normal size, in this case, it is smaller than usual, of course, the workload it would carry would be somewhat greater, and so it wouldn't be functioning to the capacity that it should had it been of normal size. Genetics, persons who are predisposed with chronic kidney disease and end-stage renal disease is 3 to 9 times greater that there is some family member with end-stage renal failure. Similar to what I was explaining before the break, where you have one or both parents or close family member with this disease, you're already predisposed to have it. And it is how genetics work. We cannot escape it. Race. Studies have shown that African Americans are nearly 4 times as likely to develop end-stage renal disease as Caucasian Americans. Asian Americans and Hispanic Americans and Native Americans are at risk because they are twice as likely to develop diabetes than their persons of other descent. So let us look at the symptoms, and these are what would alert us to some extent when we should go and seek medical attention.
Yes.
Whether it's urgent, non-urgent, or begin the screening process, especially if you are already predisposed for chronic kidney disease. So what to look out for? Persons having trouble sleeping, poor appetite, weakness, more tired than usual, itching, weight loss, muscle cramps, swelling of the feet or ankles, anemia, the need to urinate more often, especially at night. Most people do not have any severe symptoms until the kidney disease has advanced, like we explained earlier. Now bear in mind, these symptoms are also symptoms of other conditions. Again, the importance of screening. Okay, we're going to always stress on that. And especially, again, if you are already predisposed to chronic kidney disease. Complications. We have there the anemia. Reason being, the kidney participate in the production of red blood cells. So if the kidneys are not functioning properly, it can affect the production of red blood cells, which would affect the overall blood count. It gets low. That's the terminology for anemia. Weak bones. Poor nutrition, nerve damage. Kidney disease also increases your risk of having heart and blood vessel damage. These problems may happen slowly and over time. And as we said, that phrase is keep repeating, okay? Slow and over time. End-stage renal disease complications such as shock, sepsis, bleeding, hyperkalemia, hypertension, congestive heart failure, pulmonary edema, pericarditis, peptic ulcer disease, and metabolic encephalopathy. Now, from the emergency standpoint, remember earlier I made mention of screening being done at the health centers or with your primary care physician. Even we in the emergency department have to know how to treat a patient with chronic kidney disease. Not that we are doing screening at the emergency room, but from time to time they may show up with one of those symptoms I just recently mentioned of, and we have to know how to go about treating them, especially with drug type selection, to be cautious with the administering of fluids, because remember the kidney is not in a position to filter fluids the way it can. Sometimes you just cannot administer fluids. Sometimes they present with fluid overload.
Oh, wow.
And yes, and then you'll have to know how to eliminate that excess fluid. Sometimes these crises happen in between scheduled dialysis treatment, and so from time to time, when the case is a bit beyond our scope of management, we would even have to consult the specialist, the nephrologist, as to some guidance on the management of these cases. Wow. So again, we don't do screening at the emergency room, but we have to know at the same time how to treat a patient with chronic kidney disease. If by chance they happen to get complicated or presenting with some other common illness.
That's interesting. So if the person has kidney issues, then the healthcare professional would really have to know if they can or cannot administer drips.
Yes.
Because, you know, that makes a lot of sense. So then if the person themselves may not even sometimes know that they have an impaired kidney, then they can definitely, I guess, end up with hypovolemic shock.
Correct.
Interesting. I've never thought about that, but that makes total sense. So we really have to be careful, because going to the hospital and to the different medical care systems, administering drips is very almost routine in a lot of situations. So it's important for us to really understand the severity of the kidney diseases that we have when persons present in the emergency room care, because then I guess it can complicate matters more than is necessary, because then if the person ends up with hypovolemia, then it poses a immediate threat again, and then the medical personnel would have to figure out now how to drain all of that. Oh wow, understood.
And so, and as we help you during this session with education awareness, we too do like your honesty in letting us know your condition so that we can know how to properly treat you if you do present to any of the emergency services.
Okay. So we can go through what? The complications of kidney disease?
I already did.
Okay.
Yes.
Okay. And so let's move to how kidney failure is diagnosed. So at the health center or with your primary care physician, they will do a number of testing. Okay. Again, screening, and it is to evaluate how the chronic kidney disease is progressing, whether rapidly, because I remember when I was a student, there was this patient in stage 2, and in 3 months' time, they progressed to stage 4.
Wow. So it can jump.
It can jump.
So it's not like a steady progression all the time.
Nope.
Oh.
It can jump. It can jump. And so that's why patients and their primary care physician, they have to stay on top of the game with managing patient and patient knowing the condition, listening and carrying out the instruction of their doctors.
And as you say, they have to do the once a year, the checkups.
Yes, sometime by annually, depending on how the condition is, so that their situation won't get out of
control.
Once it is within some level of control, that would eliminate the need for frequent visits. But again, you cannot just negate the fact that, hey, all is well and I can ease up now. No.
Okay, interesting.
So amongst the testings, okay, we have blood tests. In blood testing, we look specifically at the renal profile. So you hear the terminology like burn, creatinine, sodium. Okay, these will evaluate how the kidney itself is
eliminating the waste.
Is eliminating the waste. Okay, you look at blood level. Okay, the hemoglobin. You look at cell structures. Okay, all of these is to help to complete the evaluation.
And the profile, as you say.
And the profile. Because of the affectations on the liver and the heart, liver profile and cardiac profile can be done as well. Okay, when it comes to urine, we look specifically for there's this termination, the glomerular filtration rate, where in the slide before where it was listing the stages, that is one the key indicator to in evaluating the stage of chronic kidney disease. You look at how the kidney is eliminate, if it is eliminating other waste, proteins, glucose, which should not be happening. So definitely there's some damage along the kidney. And
blood.
Yes, I made
blood. Yes.
Pardon?
Blood.
Yes, I made mention of the blood. Imaging. So the imaging there would refer to
ultrasounds,
CT scans, MRIs, and in some more advanced stages and with certain abnormalities, biopsies can be done as well. Yeah. Okay. So the person.
I've heard of a kidney biopsy.
Yes, you can biopsy any part. So they use a very long, fine needle.
I know about the
very long, fine needle, ultrasound guided.
And where does it enter? Where does the needle enter?
Shortest
The
distance.
urethra?
I don't remember where, but collect that sample and then they'll send it to the lab to be viewed by the pathologist under microscope.
Biopsy is more for looking for causes of chronic kidney disease, of types of glomerulonephritis, not specifically for diagnosis of chronic kidney disease. No, it's for looking for causes of chronic kidney disease.
Okay, interesting. So maybe the doctor, dear guest, can you tell me what's the entry point for the biopsy? Where do you enter?
Yes, you enter the needle, take sample.
Where does the needle enter?
Here in the back.
In the back?
Yes. You, yes, by ultrasound, you locate the kidney, and in the inferior pollute, you put the needle and take a tissue.
Okay, gotcha.
Okay. So I made mention of those already. Let me see if I miss any. Okay, we are good.
Yes.
So let's move on to some of the available treatments for chronic kidney disease. So, of course, in treating chronic kidney disease, we look at reversing some of the modifiable risk factors. We look at treatment control. We look at once those are not working, okay, and if it has progressed too rapidly, or you're at 4-5 thereabout, begin to consider dialysis. Okay, the dialysis and kidney transplant are the two main treatment for.
I suppose we don't do kidney transplants here on the island?
Correct.
And the kidney transplant thing is a complicated thing too, because you have to be on a waiting list, and the kidney has to match.
Yeah, I'll touch on it.
You can touch it?
The dialysis treatment of transplanted kidneys will take over some of the work of your damaged kidneys by removing waste or the extra fluid from the body, and this would make many of the symptoms that the patient is presenting a lot better. In the case of dialysis, there are two types, just in case you do not know. There's what you call hemodialysis and peritoneal dialysis. Both remove waste substances or the extra fluid from the body. In the case of the hemodialysis, what it is actually an artificial kidney, since that of the sick person is not functioning properly. You get hooked up to a machine, as we just say, drains out the blood accordingly, filter it, get rid of the waste, etc., and then it's recirculated. That is the filtered blood
Back into the body?
back into the body.
I've always wanted to know, does the patient feel weak while doing this?
Yes, because remember, they are losing fluid. Okay. So they are connected to monitors, and it is something happen. It is timed, okay, and so that the rate at which it leaves and go back in
is balanced.
Yes, there has to be some balance, okay. And in the case of the peritoneal dialysis, okay, this can be used when patients do not necessarily need hemodialysis. So instead, there's an incision made in the abdomen with a tube, a flexible tube. Fluid is passed there. It mixes, okay, it's isotonic, okay, so it mixes, it absorbs some of the waste, okay, and then it is filtered back out. So that's one of the options.
And how much time does all of this take?
That I don't know. A few hours. Well, again, it's the same gradual procedure. And then in kidney transplant is where a healthy kidney is placed into the body of one that has a damaged kidney. Okay, so that's when you're at stage 5, basically. Persons, they'll be on a waiting list. You have to wait for a perfect match. Sometimes it's hard to get donors, be it someone willing to donate one of their good kidneys, be it the cost in some settings, because these things do sell, okay?
On the black market?
Yes. So, so you just be there waiting for that perfect match while you're getting your dialysis treatment to control some of your.
And I guess in some
symptoms.
Cases, your body can reject the donated kidney. You can have a allergic reaction, is it?
Rejection, basically. So once you have a transplanted kidney, you're placed on medication for life to prevent rejection of that kidney.
Oh, okay.
Yeah.
Understood. So, doctor, how long each dialysis session, how long does it take each time?
Hemodialysis is different in all patients, no? But more frequently is 3 times per week and around 4 to 5 hours.
So it's 3 times a week and 4 to 5 hours each round for the hemodialysis. So I'm taking it that if you're a younger person with a family to take care of, with a job and a career, being placed on dialysis can be severely, it can really be incapacitating to the person. So these people who are on dialysis, are they not working? Do they have steady jobs? Do they have a career?
No, in this case, it's better peritoneal dialysis, okay? Because peritoneal dialysis is possible at home.
Okay.
And when the patient is sleeping, the patient connected to the machine himself and sleeping and receive the dialysis treatment.
Oh, so
it's better, yes, in younger patients when the patient go to school, or in elderly patient when have some heart problem. It's better peritoneal dialysis. But if the patient can receive peritoneal dialysis and is in hemodialysis, we can accommodate the patient according to the job, the school.
Okay, so it depends on their lifestyle, and then the doctor would try to accommodate and suit the person's lifestyle, so it's not such a big impact. Because I was thinking, if you have every other day, like so it's basically 3 times a week for the hemodialysis, 4 hours each. So I'm wondering, like, how do these people work? So then the peritoneal dialysis would be better for a younger person with a career, because it's done at home and you can do it while you're sleeping.
Yes.
I think I prefer that. But then, I think there are risks involved in this, like in terms of increased infection if the patients are not careful with the way they handle their at-home hygienic handling of the area. Is that so?
Yes, the patient needs to training. The patient and the family training very well before receive dialysis at home. Of course, need to be careful to everything need to be disinfected for avoid infection in the abdomen.
So you guys carry out regular training sessions for families with newly diagnosed people, and we go through the motions. So you find that they're compliant in terms of following the instructions, or do you have a lot of challenge in that area?
The patient receive the training, and when finish the training, is evaluated, and we can know if the patient have condition to start it at home.
I understand. That's good. That's nice. I like that.
Yes.
So,
back to the slide, please. So, again, for the same reason we are here.
Prevention.
So under prevention, we have the control of blood pressure, diabetes, and I would add any other non-communicable disease that one has. Do your lifestyle adjustment, exercise, get optimal body weight, take your medication as prescribed by your primary care physician, maintain your checkups, and for the topic of tonight, get screened. Okay?
Yes.
Have that talk with your primary care physician to get screened. And diet plays a big role. Okay, so in speaking with your primary care physician as well, one could also get advice from a dietitian as to the amount of calorie, protein, etc., because it would be an individual plan based on how advanced you are, your body weight, the type of work you do, because it's different for somebody working out in the field as opposed to working in an office, etc.
Gotcha.
Yes.
Okay. And this one is saying get tested regularly, and you even mention annually or biannually if necessary, depends on your condition.
Okay. So, is there more? Is there another slide? Yes. Okay. Take your medications as instructed by your primary care physician. Quit smoking. And, of course, nephrology consultation would be necessary to help to complete the workup and management of the case. All right? It's good to have the specialist eye in on it eventually, even though you have your primary care physician doing the initial assessment, control, etc. At some point, the nephrologist would have to intervene and sometimes adjust the treatment plan as they see fit.
Gotcha.
I want to add to the men more than 50 years old need to screen the prostate problem. And the people need to avoid the medication for pain.
Yes.
Pain medication.
Yes. I forget to make mention of
not
that.
the steroidal anti-inflammatory drugs can produce chronic kidney disease.
So one example could be like paracetamol,
ibuprofen, Voltaren.
Yeah, they do damage the kidneys over time.
Yes.
So those who have chronic pain issues, these non-steroidal anti-inflammatory drugs is not a good option in terms of the chronic management for pain.
Wow.
Yes.
Okay. That's interesting to know. So, in conclusion, I guess we can open up the telephone lines at the moment. If the general public, anyone has any questions that they would like to have answered, we'll be on standby for the next 15 minutes taking calls.
Repeat the numbers.
Can we quickly take a break for a minute?
It's a sore throat. I'll write a prescription and see the nurse regarding the MMR vaccine.
I heard on social media that the COVID-19 vaccine came in a container with the MMR label on it.
Measles, mumps, and rubella vaccine is in the vial, no other.
True?
We can't betray our parents' trust. St. Kitts and Nevis has always had an impressive immunization history.
But these diseases aren't around now.
Yes, our borders are open to all kinds of diseases that negatively affect our children and elders.
I never thought about that.
Today, you have a choice whether you get vaccinated. So, you want to continue?
Yes, doctor.
I want to be protected.
Check your doctor or the Ministry of Health to get the information on immunization against childhood diseases, including HPV and polio, and COVID-19 vaccine for elderly persons and persons living with non-communicable diseases.
What did you mean earlier about climate change, Mom?
Well, when I was your age, I remember beautiful coral reefs and healthy beaches. The summers weren't as hot as they are right now, and the rainy season meant that it only rained when it was supposed to.
And then what happened?
The weather just started to change, and storms got worse. Coral reefs started to die because the ocean was getting too warm, and crops started to die because there was not much rain. You know, we realized as adults that we were doing something that was causing this.
What were you all doing?
The same thing we're doing now. Not using clean, renewable energy, chopping down too many trees, and even polluting the air with gases, such as the gases emitted from our cars when we drive around.
We need to help before it's too late, Mom.
We can't let it get worse.
What can I do?
We can raise our voices.
With 35 million dreams, aspirations, and futures at risk in Cari Forum, we need your voice in our story against climate change. Acknowledge, commit, act. This message is brought to you by the Caribbean Community Climate Change Center under the Intra-ACP Global Climate Change Alliance Plus program and is funded by the European Union.
Good evening again and welcome back. So we're going to continue our discussion about the prevention of end-stage renal failure. So Dr. Pemberton, we're going to continue our discussion as we were before we left the break about the different types of dialysis. I was asking the specialist here about how do we decide which treatment will be right for what patient? So she elaborated for me and she told me it's about their age, their lifestyle. Yes. And so if any one of you guys would like to give any elaboration or any sort of case scenarios with any of the patients, any complications that we have, the challenges that we might face, because I don't know how it is here, but I know overseas, for instance, there are organizations and programs in place for early screening. I'm not sure if we are on the good foot here yet in terms of having a standardized protocol in terms of, okay, well, the patient has uncontrolled diabetes for a year. How soon, how do we go about collaborating with the primary care physician and say the specialist? How do you guys collaborate with the primary care physicians to get the patients to be screened earlier? How do you guys do it at JNF? Or is there anything in place where you guys are able to communicate with the physicians of these patients? How do you guys go about that?
All diabetes patients need to follow up every 3-4 months.
3-4 months, so they have to get tested like more than twice a year then? Maybe?
Yes. In this clinic, the patient need to check, of course, blood pressure, blood sugar, and tests for screening. 24-hour urine protein, looking for protein if the patient has previous history of damage in the kidney. If never have any damage, we need to looking for microalbuminuria in the urine, because this is the marker for damage in the kidney. And specifically treatment according to the stage. Okay, control, when we talk about control of blood pressure, is less than 140/90, because sometimes the patient say, no, my blood pressure is okay, and it's not okay. It's not okay. It's more than this. 140/90, but in patient with a previous problem in the kidney in diabetic patients, some doctor recommended less than 140/80, or sometimes over 75, for avoid the protein in the urine. And the filtration, the glomerular filtration rate, looking for if the patient start with chronic kidney disease and in what stage is in. Of course, the control of blood sugar is with HbA1c, and the patient need to be less than 7.5% of that for the control. Okay?
Understood. But we didn't touch much on any acute kidney malfunctioning. Like, for instance, if a person gets into a traffic accident and
acute is another topic.
It's another topic altogether.
Because acute is reversible.
It's reversible.
It's reversible.
That's what I wanted to know.
Yes, it's reversible.
It's reversible.
Yes,
but not the other one. The chronic
not
one
chronic.
is already too far gone, so it's the damage has been done basically.
Yes.
So it's no going back from that.
No going.
Okay, interesting. We have anything to add, Dr. Pemberton?
Well, slightly different topic. In preparing for tonight's topic, earlier we made mention of the effects on some drugs with the sex drive, the effects of the analgesics, their prolonged use, and the damage they can cause to the kidney. And within the scope of prevention, control, diet, etc., of course, I tap into a bit into some of the natural remedies. And what was persistent is the use of garlic, onion, ginger, okay, and watermelon. Now, the watermelon is one that has to be monitored. Specifically, it tends to be sweet, okay? So the diabetics, remember we have diabetics with chronic kidney disease.
So watermelon is too sweet for them?
Not all watermelon is sweet alike, but the sugar would have to be monitored, okay? You know, some people, they tend to abuse stuff like currently they're going to be abusing the mangoes, all right? So with the watermelon, the diabetics with chronic kidney disease has to be careful with the use of watermelon. And two, why the watermelon in particular is also helpful is that it is low in potassium, okay? One of the products in the urine waste, which if elevated can be life-threatening. Okay, that's it. It can
potassium.
Yes. So the watermelon, what it does, it would reduce the potassium concentration. That's if it is high in blood. Okay. So that too has to be monitored so that it is within normal range as well.
Interesting.
So just a little addition on some of the natural remedies out there. As to the preparation, etc., I can't say at this
I was
moment.
about to ask you how do they use the onion and garlic if it's
I would assume more like a tea, like a mash. Again, one has to be cautious as to the concentration and frequency of use.
Gotcha. It's very interesting. Would you like to, do you have a lot of your patients using natural remedies? They come to you?
No.
So you
not really. But the patient with chronic kidney disease need protein restriction for avoid the waste substance. And that's why coming sometimes to desnutrition. Because we reduce the protein in the intake, we reduce the fruits, some fruits and vegetables because are high in potassium, avoiding hyperkalemia, potassium high, and the patient can come into desnutrition. That's why it's very important followed by nutritionist too, dietitian, because we suggest low protein, but the patient need to know exactly the amount per day for be low in protein but avoid the dense nutrition.
So it's going to be low in protein but high in carbs?
No need to
What's
high
the
in
balance?
carbs. No, low in protein, low in carb.
Low in protein, low in carbs.
And the control of the potassium.
And the control of the potassium.
Yeah.
Yes.
Oh, that diet does... Oh.
It's difficult.
And so it's difficult because imagine you have to be battering, as we just say, taking your medication on time, or don't miss not missing your dialysis appointment, having to eat properly. Sometimes certain foods are not readily available because it might be seasonal. It has to be prepared a certain way, and so it does pose a challenge on these patients.
I agree. So you have to work closely with the nutritionists. You work with them and the patient, and you come up with a nutritional plan that they have to follow?
Yeah, yes, we have nutritional at the hospital, and in outpatient department, we can send the patient to see.
That does not sound very fun, like low carbs and low protein, so they basically can't eat much meat.
Yes. And low protein is low meat.
And then low sodium if they're hypertensive.
And low sodium too. Yeah. And low sodium too.
Because the sodium would increase the blood pressure and cause more damage on the kidney.
I'm trying to figure out, what are they going to just eat? Just oatmeal and water?
No,
it's just difficult.
It's the amount. The problem is in the amount. The protein is 0.8 grams in 24 hours.
So you have to, like, it's portion control.
It's better white meat than red meat, for example. And the nutrition, according to that amount program, the
meat
daily.
So they can have pork. White pork is white meat.
Chicken. Yes, chicken. Fish.
And fish
are better than
Doctor's laughing at me. I thought they said pork was the other white meat.
I used to always say so.
Okay, so I guess it's not pork. It's chicken and fish.
Yes.
And low sodium.
Chicken as in birds.
Yes, because high cholesterol and high triglyceride can affect it to the heart and the kidney.
So I'm starting to see why we're having a problem.
That's why pork is not good. Yes.
I'm starting to see why we have this issue, because we as Kitishans, we like to eat and we like flavorful food. So I can't understand, or I would never be able to put my head around low sodium, low protein, low carbs. I feel like I won't end up with anything on my plate.
The patient need to avoid the processed food. Okay, if the patient cooking a chicken, for example, I am not nutritionist, but if the patient cooking the chicken and put any salt, additive salt, but maybe some vinegar or some spice, not too much.
Vinegar would be a good substitute for salt.
Yes, and rice and some vegetable. Okay, because we know the patient need to stop the vegetable and fruits. Need to avoid that vegetable high in potassium. Okay, but can continue eating some vegetable and fruits. For example, apple is very good, and it's better. Eat the fruits that no juice. The patient need to drink water and no juice. Need to avoid the soda, and the patient need to learn.
That's interesting, because one modification that I saw when I was in med school overseas was what the government did was to make certain unhealthy foods more expensive. Like, for instance, sodas was way more expensive than green tea. Well, I studied in Taiwan, so then green tea would cost like 25 cents, and then a soda would cost like $3 US. So it's a huge difference in price. So patients with diabetes and hypertension, they had no choice but to stay away from the soda because they couldn't afford it anymore. So I'm not sure if at the governmental level we can.
No, but the soda is not good. And are high in sodium, in potassium, in phosphorus too.
So soda is not good at all.
Not good at all.
So maybe we can lobby with the government to start with soda. Soda was a big arch enemy in Taiwan for health, right? Okay, so I think that was a lively discussion. Anyone has anything else to add to the topic?
To the topic, no, other than to encourage persons to look out for the signs, symptoms, especially if you are already predisposed and saying you have one or two parents with history or had history of chronic kidney disease, persons who are already diagnosed with this condition to adhere to the advice of their primary care physicians, to do their regular checks, follow up with the specialist, do your diet, lifestyle adjustment, etc. And try to live as long as possible and as happy as possible with this condition. Right. I know it does be a ticklish one, like I made mention earlier, in terms of the dieting in particular, the cost, because medications are costly, hemodialysis, peritoneal dialysis, they are costly. Even the government would have reduced the cost.
That's a good point. How much is it to do dialysis here?
I don't know.
You know how much is the cost, no?
A few hundred, well, per session. Okay.
Per session?
Per session.
Wow.
And kidney transplant is more expensive.
Yeah. And then one has to always look at the burden it would carry on the healthcare system in general, because these are persons who are within working age, who can be out there being more productive for the economy. One has to look at not necessarily jump to that, but the overall cost that the government has to bear in terms of subsidies, etc. And also too, recently we got a donation of 15 hemodialysis machines, which would sort of ease the scheduling and the rotation of those who are already getting their sessions, hemodialysis sessions. So there would be a faster turnover. Not that we're encouraging persons to reach that stage.
Exactly.
Okay. We are not promoting bad health. Okay. We want you to prevent this by all means.
Yes, good advice. Thank you. And at this point in time, we're going to wrap up our discussion this evening. And I would really like to take the opportunity to thank Dr. Dieguez and Dr. Pemberton for taking time out from their very, very busy schedule. I know Dr. Dieguez, her hands is very, very, very full. And I know I'm going to have to ship Starbucks from overseas just for her. And I appreciate her so much. I thank you for coming and sharing your knowledge with us. And for Dr. Pemberton,
yes,
I thank you for coming and sharing your expertise with us as well and your clinical experience. And to all of you out there in TV and radio land and internet land, thanks for tuning in and for being a part of our discussion. Thank you.
Apologize for not coming.